Io sono Laura Celeghin.
Good evening. My name is Laura Celeghin, and for the past 30 years, I have been organizing GiovedìScienza with all my colleagues. I would now like to give the floor to Fiorella Altruda, who is a genetic expert and who is the director of the Molecular Center and is also a member of GiovedìScienza. Good evening to you all. I'm a little embarrassed to have the role which for 30 years Piero Bianuccio had, who is not with us here today. And so it is for me an honor to introduce colleagues and friends and all those who will be talking about this disease. And therefore, with the intention of clarifying the problems, the possibilities, the treatment, diagnosis, they will talk about it, of this, shall we call it, disease. We have Professor Chiara Benedetto, who is the first chair of Obs and Gynae at the University of Turin, and she is very authoritative in the field of breast cancer. She is also president of a European board of Obs and Gynae. Then we have Giorgia Zucchini, who is an oncologist in Candiolo, and for years has been involved in the study and treatment of breast cancer. And then we have Manuela Arata, who is the founder and chair of the Science Festival in Genoa, which is very prestigious. And then we have an actor, Teresa Mannino, who needs no presentation. She's well known because of her monologues and the spontaneity she has on the stage. I'd like to leave the floor to them and then the floor to you.
Allora, io intanto ringrazio Laura Celeghin.
First of all, I would like to thank Laura Celeghin and GiovedìScienza for this invitation. And although it's Science on a Thursday and it's a Saturday today, that's fine. In fact, I was extremely pleased because for many years I have been sharing scientific subjects with the citizens, and we've had different things in the Science Festival. Very often we've spoken of diseases, but very little of this one, which is widespread and which requires people talking about it. I think there have been many campaigns for prevention, but this afternoon we wish to talk the various subjects. You too will have time for questions and give your own, because we talk very little about cancer, very little about this female cancers, in particular this one. Personally, I have brought this hat because I keep it with me, because when I had chemotherapy I was always cold, and this changed my life completely. It was a very important, extraordinary human experience which gives you a different yardstick in life. So I always have my hat with me when I talk about these things, which is why I was particularly interested in coming here today. I think we don't talk about enough about it. It's not a campaign which doctors only carry out. It must be a general campaign because, as you will realize, there is a world around us. Now, we always start with the basic and accurate scientific information, but because that's a must. And then we have all a possibility to access information. We Google very easily, and you also read a lot of things that are inaccurate, and people then worry about things that are not accurate, and we then have to talk to the people who actually have the knowledge. And I would like to start with Chiara Benedetto, who can give us an idea of how widespread it is.
Pensate che una donna su 8 nell'arco della vita.
Let's start with numbers. Don't forget that 1 woman out of 8 in her lifetime has a chance of being affected by or suffering from breast cancer, because it is the most frequent cancer amongst women. In Italy in 2014, there were about 48,000 new cancers, and that's about 3,300 new breast cancers a year. What has happened in the last 50 years is that the frequency of this cancer virtually has trebled. Luckily, progressively, also the treatment has improved thanks to the greater accuracy of diagnosis and to the progress which has taken place in treatment and early diagnosis. At this point, you might ask yourselves, why? How has it become more frequent and increased threefold? The increase in numbers is mostly due to the fact that given that we have screening programs, these are diagnosed earlier on. And as you well know, the screening program known as Prevenzione Serena in Piedmont, that is to say, prevention program, offers women from 45 to 65 with the possibility of having, 45 to 50 once a year, and from 50 to 65 once every 2 years, they will have breast screening. But it's not just the breast screening that has increased the number of cancers. There have also been some changes in the way in which women live in the past, or have been living in the past 50 years. First of all, we live longer, which means that there is a greater chance of developing cancer as time goes by. And also certain habits have changed. For instance, they drink more alcohol. Very often, they're overweight in menopause, and above all, they tend to have their first child at a later age. And this is a major risk factor, especially if the first pregnancy is after 35. As far as the risk factors are concerned, as well as age, being overweight, late pregnancies, and alcohol use, there's also the family history. And in this respect, we know that 5–7% of these cancers is linked to genetic problems. For example, the mutations of 2 genes appear, BRC1 and BRC2, and the women who have this mutation tend to develop this cancer before 40. Then there are other risk factors, such as the early onset of periods, late menopause, not having children, not breastfeeding, not having had children, stress, and other factors which can be modified, such as lack of exercise, a diet without enough fibers, a low-fiber diet with a lot of animal fats. And therefore, what can a woman do to try and decrease the risk of developing this cancer? Well, clearly, we would possibly have to be the same weight throughout our lives. We should try and not be too stressed, but unfortunately, this doesn't always, it's not something we can govern. We should also exercise. And simply, this might be, for instance, walking for half an hour a day. Then we should try to not to drink too much alcohol, not too many sugary drinks, not too much salt. Why? Because another risk factor is the so-called metabolic syndrome, which includes hypertension, diabetes, the increase of cholesterol and triglycerides. As a result, diet is very important, and we should avoid too many calories, limiting the use of red meats or preserved meats. Eat fruit, vegetables, and various cereals. Then we should also have a pregnancy before 35. In women, and of course breastfeed. Women who have the genetic mutations I was mentioning, BRCA1 and BRCA2, one might also consider the preventive subcutaneous removal of both breasts, which reduces the risk by 90%. Clearly, this type of operation may have functional problems, but also psychological problems. And the fallout is not always positive, which is why one has to balance the pros and cons very carefully. And furthermore, since it's very important to have early diagnosis to be able to treat it, it's also important to undergo screening. Over the past 40 years, enormous step forwards have been made both in diagnosis and treatment of this type of cancer. As far as diagnosis is concerned, we have devices that are increasingly sophisticated, which can increase contrast between the cancer and the surrounding breast tissue so that you can see it more clearly, and nuclear magnetic resonance can also be used. As far as diagnosis is concerned, we are able to identify the cancer, identify its molecular biological features and its histology, thus being able to decide what the best treatment is for every woman. This is one of the most important challenges. Personalized, customized treatment, bearing also in mind what the woman wants. As far as the surgical treatment is concerned, up until the 60s, all the breast cancers were treated with the removal not only of the lymph nodes, the armpit lymph nodes, but also the muscles with functional problems and aesthetic problems, cosmetic problems that were very negative and may have had an impact on the quality of life. Slowly, the muscles were left, and initially, in the early 80s, it was proved that the mere removal of a part of the mammary gland containing the cancer with radiotherapy on the residual breast, in terms of treatment, gave the same result as a complete mastectomy. Since then, the surgical treatment has become more and more conservative, and we've also developed all those methods which we define the so-called oncoplastic treatments, which make it possible to preserve one's body image, the body image that a woman has of herself. What does this mean? It means that in the case in which you remove only part of the breast or of the mammary gland, you try to remodel it and remodel the other one too. And in the limited number of cases where currently it is still necessary to remove all the gland, then you also consider the possibility of maintaining the epidermis, the skin, on the removed one with or without having the complete breast. And also, as far as the removal of the lymph nodes and the armpit ones, we have become more and more conservative. In fact, currently, thanks to the technique of the sentinel lymph node, we remove one, and thus, in 70% of the cases, we're able to avoid removing all the others. However, the real revolution was the one whereby we customized the chemo or radiotherapy or hormonal therapy on the basis of the patient and of the type of cancer she had. In young patients, some of these treatments can generate problems, for example, on later fertility. Why? Because some of these treatments have a toxic effect on the ovaries. It is our duty, therefore, to consider that women under 40 have to be informed and that they can preserve their fertility with various techniques. For instance, you can freeze the oocytes or freeze part of the ovarian tissue, or yet still other possibilities such as treatments which block the hormonal activity of the ovaries during the treatment. And this is important because unlike what was thought, a young woman who has had breast cancer can have a pregnancy because pregnancy per se does not increase the risk of this cancer redeveloping. Clearly, to avoid negative effects on the fetus, you have to have had at least 1 year since chemotherapy before starting planning another pregnancy or a pregnancy. And it's also possible to breastfeed. Clearly, you can plan pregnancy because pregnancy per se does not increase the risk of a recurrence of this cancer. Clearly, we have to bear in mind that to avoid negative effects on the fetus, at least 1 year will have to have gone by from the end of chemotherapy before you start planning a pregnancy. And also breastfeeding is possible. It's quite clear that in the event of a woman having had a mastectomy, she will be able to breastfeed only on one side, or in the case of her having had a more conservative operation, she will have to know that the breast she's been operated on will give less milk. What does this mean? Well, all this is the quality of life, and the quality of life is the main objective of all the players who are trying to treat this cancer. The woman who has suffering from this cancer, because it is true that the possibility depends on a series of factors: age, the size of the cancer, the fact that it may or may not have spread outside the mammalian gland at the moment of diagnosis, on the features, the molecular, biological features of the cancer itself. Let us not forget that the psychological approach and the way in which the woman feels with herself, with other people, with how she relates to what surrounds her, can help the woman recover. I'd like a question immediately, since here. First of all, I've discovered something, because I've only got one risk factor compared, because I don't drink, I don't smoke, my food, but I was 39 when I had my first child. They said, people say, have children as late as you want, but I don't think I would have had a child earlier, because you have to find the right person to have a child earlier. But maybe I could have thought about it. But having said that, amongst the risk factor, there were two: having children after 35 or not having children. At that point, is it better not to have a child, or which is the biggest risk, or having them after 35? It's worse to have them for the first child after 35. Worthwhile in any case, I'm sure. At this point, let's see the post-treatment therapy and where research is going. With reference to what has been said, I would like to start by saying that until 20-30 years ago, the cancer specialist and people dealing with cancer with specific reference to breast cancer were usually associated with suffering, and certainly with very little hope of recovering. This is because the first chemotherapy that was being used was associated with very low success rate, and also had major side effects, which seriously questioned the quality of life of the patients, and had an impact also on their families. For a long time, they were nightmares, and it was very difficult to free oneself of them in the past decades, and in particular in the past 15-20 years. The major step forwards that we've had in research have meant that this negative image has changed. In our day and age, chemotherapy for a patient who's undergone treatment for breast cancer is certainly a very hard, difficult moment, but in the course of treatment, most cases, it is possible to continue to have a relatively normal quality of life, to remain active, with side effects that are certainly more manageable. And this is possible thanks to the developments that we've had in various fields. Certainly, we have now drugs which are more effective and which make it possible to manage the side effects of the chemotherapy. A classical example: nausea, sickness, which up to a few decades ago were some of the worst side effects, which continued in time and seriously questioned the quality of life of patients. Now, most patients say that they're present but manageable and transient. This has also helped people comply, not only physically but also psychologically, as Chiara was saying, especially where the disease and treatment are concerned. Alongside the development of these treatments, there's been a revolution in the strategies of the oncological treatments, which increasingly have moved towards customized treatment. Let us go back to the history of cancer treatment as a pyramid. Early treatment, 70s, 80s, when the chemotherapy was introduced for breast cancer. when chemotherapy then had very heavy drugs with low success rates and major side effects. Very few drugs which were used to treat all patients. As time went by, moving upwards in the pyramid, available treatment, but above all strategies, have moved to customized or personalized treatment. Why? Well, because we now have knowledge on the biology of the tumor or cancer, and we're increasingly able to better define the risk profiles of the various patients on the basis of the main histological, biological, and molecular features of the cancer. This is why not all patients, the patients who've been operated on, are treated with chemotherapy. Sometimes it's enough to have a local treatment, that is to say, surgery and radiotherapy. And other times, hormone treatment is enough. Certainly, there are fewer side effects then. Furthermore, within the same chemotherapy, there's not just one type. We're not talking about a chemotherapy, but we're talking about chemotherapy. We're able to tailor treatment, use dosing the various drugs. The aim is to guarantee a better quality of life, the most normal possible quality of life. Lastly, if we now reach the tip of the pyramid, we get to the point to what our main aim is presently in medical oncology, including breast cancer. That is to say, the study of the cancer genome. We now know that cancer is not the result of a single organ, but from the alterations of the DNA, of our DNA and our genes. The main focus of research, which is carried out in major centers where we study the origin and the treatment of cancer tumors, such as the Candiolo Institute, is aimed, or the focus is, on the main mutations that underlie tumor development. Such mutations are not just, they don't only differ in terms of cancer, that is to say, breast, lung, or gut cancer, but there are also different mutations for the various patients, for the single ones. And clearly, it is easily understood how this will lead to increasingly tailored treatments, which, along with the systemic chemotherapy, will make it possible to attain great success and cure, guaranteeing, and this is one of the main, most important points, while guaranteeing an optimal quality of life for all patients. Thank you. Thank you very much. This has certainly framed our problem, and now I have to talk about it on a more personal, human level. Once the problem has been framed, this is something which affects people a lot, and people don't talk about it. As always, historically, people don't talk about diseases. When there was TB, and you didn't mention the name, and then, for example, reactions. Excuse me if I asked you, but if I'm asking you, have you a bad disease? Come on, now they're treated. And, well, You, I'm sure, have all cases, and I would like you to deal with this topic with a bit of tongue-in-cheek or a bit of irony, because certainly if you only deal with it in terms of intelligence and with awareness, that's what the doctors say, even helps us as patients to fight it. So a bit of irony, for example, I was operated on 4 times, and people say to you, are you always in hospital? And I said, yes, I was having a breast job, and that's not too bad, is it? So I'll laugh on it because I think that you have to live with these things. I must say I wasn't afraid, but I was very disquieted by the whole process. And certainly the attitude with which you deal with a topic such as this is very important. I would first of all like to ask Chiara Benedetto. I'm sure you have operated on many, many people. Are people generally more depressed or more upbeat? I think more people were courageous because clearly as soon as you're told, people get depressed, then people get angry and then depressed. But women are really wonderful. And in most cases, they then react and they fight it. And this helps. A topic which we spoke about before we started this meeting was the following. Last year, there was this American suggestion, well, since we have early diagnosis and we treat them, let's not call it cancer, let's call it tumor. I'm part of the people who got really angry because we felt betrayed. And said, well, look, I had terrible treatment. I bore it and I was gutsy about it, but in any case it was danger. Now you want to belittle it, and I'd add, I mean, would you ever do that with prostate cancer? No, they won't let them because it would belittle it. And I think that this was withdrawn in the end. But you made some statements before that, in fact, suggests the fact that you should encourage people, not frighten them. Yes, the feeling is that most of us have in communication is that if you use the word tumor rather than cancer. It's true that tumors can be benign or malignant, but in most cases, when it is a benign cancer, you say it very clearly. When you talk about tumor and you don't add anything else to it, very often we know that it's cancer. Now, the term or definition tumor has a less negative impact in our perception. It's not quite as frightening. This doesn't mean that you're going to belittle the problem, because in any case then you talk about all the treatment which you are going to have to undergo. But it's a matter also of not letting fear take the best of you, because too much fear doesn't help. Here we're talking about not about fear, but about courage. Courage is important. Active participation is very important. How important is it today? We all remember Lea Pericoli. She had a very, the chemotherapy she had was really devastating compared to the one I had, and complete removal of breasts. But in what way? What's the contribution that an individual can give? I mean, she came out, didn't she? What's the strongest thing a woman can do? Well, certainly the person's reaction is very important. The psychological contribution is paramount. For example, the psychological support, the need to react and not metabolize this problem, which appears out of nowhere and changes all things that we have. And to talk about this certainly helps a lot to deal with a difficult moment in a woman's life. I'm going to ask you questions because you have interacted with people who are suffering from it. But a very strong impression I get is that something grew inside you or has grown inside you and you didn't notice, and it's like your body betraying you, because your breast filled with some things and you didn't feel anything. There are some cases where you wouldn't discover it, as in my case, such as microcalcification. But what about self-examination before the early diagnosis? Any use in that? Yes. It's always useful to be aware of things and look out for them. In most of the cases that we see in young women, that is to say, the women who are younger, ones under 45, basically, the women mostly come because they have identified it, usually when they're having a shower or something like that. So self-examination, although it is not any use in terms of an early diagnosis, because as you said, there are situations which you can't perceive with self-examination, especially if they're very initial. But in any case, it's useful. In the end, you shouldn't, however, make people feel guilty if they don't want to have self-examination. There are some women who say, no, I don't want it. I want a doctor to, because otherwise I get frightened because I feel as if there are growths everywhere. So I think you have to take both sides of it. If you feel that you can do it, it's certainly nothing that's going to harm you there. When you talk about tumor and cancer, I'm not afraid, but but I'm frightened now. But we should talk about it because I discovered things that I didn't know. I feel when I was at home, because my father's a doctor, my brother is a doctor, and my sister is a doctor. So when we were having lunch, I studied philosophy, and then I became a comedian, and I said, goodbye, you're in a hospital talking about deaths. But when patients phoned, because I was the only one at home, I then used to give them advice and prescription. But I would like to, what would you prefer? I'm asking the audience now, cancer and tumor, because you can talk maybe more than us because you've had it, but if they tell me cancer, I would say, right, no hope. But tumor, I don't say wonder, but I would say you're still frightened. You know that you have to deal with something. So maybe let's have a quick show of hands. There, you have to vote. How many are in favor of the word cancer being used? Very few. Can males vote? Yes, males can vote because they'll get the prostate cancer too. So, come on. How many people would like the word tumor used? No, there are more. That's an instant show of hands and an instant poll. For a while, since I have virtually no breast, I would said, how could I get cancer? Well, my doctor said you have to self-examine. You have to also carry out the test. But to carry out mammography, if you have no breasts, you laugh good of you, bastards. But I assure you it's terrible because they can't. Now I've got padded breast, but because I have pads in my bra. But once a year, is it enough, or should I have it every month? Because it really hurts. Because listening to you, I really wanted to. And another question, because you know everything and I don't. Now, what's the percentage of people who are successfully treated? 0. Thank you. I'm very pleased to have been here. 0. The possibility of recurrence depends on a series of features. Yes, but what are your figures? It depends on the stage of the disease, when a diagnosis, on the type of tumor. So it's very difficult for me to give a percentage, a global percentage, because it wouldn't be right. Because there's a wide range which depends on all these factors. However, having said that, the possibility of treatment currently are very, very high. We're talking about 70–80%. What was the other question? How often? Once a year in your age group is fine. Well, how old am I? Because I think you're wrong. I'm 44, so I'm at risk. My first daughter at 39. Once a year is fine. Once a year. One thing that was being said, but I haven't heard it said after a while, people used to say, if after 5 years you don't get it, you're okay, but it recurred after 9 in my case. Yes, this is possible. Usually, if it comes back within the 5 years, it's a little more aggressive, usually. But in this case, too, there are no steadfast rules. It's, again, the person who will have a difference. In fact, if you check on the net and you look at percentages, you immediately get frightened. You must always hope that you are in that group which survived it. I must say that in my case, since I studied at a because at university, I had a lot of people who studied. I have become a point of reference. So if anything happens, they said, phone Manuela because she'll give you advice and you can survive. I remember a friend of mine who did not have breast cancer, but something much more difficult, and so went to a specialized center where they said there's only one type of treatment, we're experimenting it, and we will include you in the experimentation. She started screaming and was phoning. I'm not a guinea pig, you know. And she didn't want to carry out or undergo the experimental treatment. She was operated on. She had recurrences. And now she has joined a special association which refers to a particular group, and then phones me and says, look, there's a new molecule we're going to be experimenting. Will you talk about what you're experimenting? Experiments and research in a clinical setting is a key point, which is part of that pyramid which I described earlier on. So if we can talk about evolution in the oncological treatment and personalized or tailored treatment, it's thanks to the protocols which make it possible after a preliminary phase, which are called preclinical ones, to test drugs that are called safe. That is to say, they have been tested in the early phases on humans and to be associated to the standard treatment of the time, to progress and to try and find treatment which is a treatment which is increasingly effective and tailored. So that means that not all patients will be eligible, but certain ones will be, certain groups of patients with certain types of breast cancer. For instance, in our center, we have various protocols, research protocols for our patients which require a selection of the population. So it's not for everyone. I think this is a fundamental part of treatment development. This follows experimentation on animals. This should be said. We should not forget what is happening in this country. Yes, experiments on animals is the starting point without which the molecules could not enter the other phase, which is experiments on human beings, which means that we could not talk about revolutions or developments in treatment. I don't know if I am violating your privacy, but if you would like to raise your hand and say, I went through it, and something very important which I feel and hear, it's an experience, painful experience. It enriches you in many respects. And in any case, I think that everyone feels as if they're part of the club, especially sitting there for chemotherapy. I've seen, because if you have the operation, well, operations, so you go into the hospital and then you go away. But while the most significant thing is when you sit down on that armchair and says, me, Manuela Arata, I am now undergoing the so-called chemotherapy. And there's a lot of people who go through this experience get very close, and there's a difficulty in thinking that people who haven't gone through that experience will understand you. You've seen many people go through this. For example, how important is it that a woman who is changed in her femininity also has someone close to her who says, you're beautiful, you're desirable, or you do see a negative reaction in the husbands? Do they become like a dead weight? And I would also like to ask the audience after you've answered, because there are people who might be pleased to talk about this. I think it depends a lot on who the husband is, as always. It depends on the person's sensitivity, and in this case too, it's very difficult to generalize. And the wish to share this varies. Some women want to share more with the men than others. There's some who'd like to be like an animal that find a corner and prefer to be on their own, while there are those who prefer sharing, and this helps them. So I think what you must do is respect what the women want. Yeah. Yes, I agree. Different people have very different ways of experiencing this in a very different way. So there are those who close up like a clam and refuse to be accompanied or to receive the help of her family members and friends, while there are those who every time needs when someone, and it might be a partner or another member of the family or a friend, but clearly it may vary from person to person. At this point, I would like to leave the floor to questions. Let's have a few questions, and then we will have answers. I'm sure there's a group here, and they're called the Dragonettes. Is there a Dragonette who would like to tell us what you do? Good evening. My afternoon is Sylvia, and I'm a representative of the Dragonettes of Turin. We're a sports team. We're a group of women. You can see us here. And we work on a dragon. We're a dragon boat. It's a 20-woman crew, and all together we reach a result. It's symbolic too. There you are. There we're on our dragon boat. Amongst ourselves, there are not just women who had breast cancer, but we're a group, a mixed group, very lucky, because in our group there are a lot of women who are supporters of friends who enjoy this sport. Certainly, for those of us who had breast cancer and who have a more or less invasive operation, especially on the arm, is a victory. It's a victory for us. We're very pleased, and helps us overcome depression and so on. And it also improves our lifestyle. As the professor was saying earlier on, you fight cancer with a healthy lifestyle. And within possibility, because we're not all young, but this is quite a demanding sport. It's not just I go for 2 miles a day sort of sport, but we like it and we enjoy it. And in time, we're increasing in number. Since 2012, we've become a registered charity. And we also compete because we're in Turin, but in all of Italy, there are these teams. The first one was in Florence, then Rome and the Venetian area. Next June, we'd like to invite you. And as we're a sports capital here in Turin, at the end of June, 27th and 28th, we will be competing, and we hope you can come. I think it's very interesting and very emotional.
Bravo.
I'd like to know if amongst the risk factors which were listed before, you can also include cigarette smoking and the use of contraceptive hormonal treatment and also HRT. Very big question. The reason why I did not include smoke amongst the risk factors, the most important risk factors, is that in most of the studies, smoke appears to increase risks of this type of cancer. Well, smoke we know is bad for everything, but it's not so clear-cut as far as the famous hormone treatment. You're giving me the opportunity to make some comments. On the whole, I must say that to date, most women when they hear talk about hormone treatment, thinks of something which is absolutely negative. Hormones are bad for you. Isn't it a pity that we are as we are to the fact that we have hormones? So, as far as the specific question is concerned, contraceptive treatment with estrogen and progesterone, it has been proved that there seems to be a small increase of risk in women who have used estrogen and progesterone for many, many years before the first pregnancy. But this risk ceases when 10 years after that. 10 years after, it's zero from the end of the treatment. And we should bear in mind that the age group in which a woman usually takes contraceptives of this type is an age group where we have very few cases of breast cancer. So in absolute terms, the risk is very low. So it's a problem always of considering the risks and benefits. There is nothing which has only advantages and no risk. Every day we get into a car, and surely there are many more risks driving every day, but we don't think about it. So it's always considering risks and benefits. As far as HRT is concerned, what we know is that there may be an increase of risk which is not so high. We're talking about, in the worst cases, with a certain type of treatment and not with others. If you use it for more than 5 years consecutively, of about 1.3, which means that if a woman has a risk of 10, this risk of 10%, this risk becomes 13, or which compared to a risk to a first pregnancy after 35 is very, very low, because the first pregnancy after 35 years increases the risk of 3-4 times, 3-4-fold. I didn't hear that, I didn't. If you continue to frighten her, it's important because the perception is completely wrong. Can I ask you a last personal question? Maybe they don't care. But once you've had the first, do you have any more risk once you've had the second one? Perfect. No, you can have. Sorry, then I must go. Not for the performance, but last question, because then we really have to go, because we have to. The theater wants the place. Good evening. I would like to know about nutrition, the importance of nutrition, both in terms of onset and also in treatment. How important is nutrition? I'd like to answer, because you've already listed a wonderful list. For example, eliminating a lot of good food. I'm talking about good food during chemotherapy. You're lucky because you have bagna cauda in Piedmont, and don't forget it, because if you have a nausea, this is also true when you drink, but during chemotherapy, that nausea, now they're not as bad, but you really don't want to eat. Then a person who'd had it in the 80s, she said, prepare the cadea. I don't know. It's the meat that you can buy, which used to be given once to the anemic patients. And I was eating this cadea, which was absolutely disgusting. But then I discovered that the best thing was tomato juice, artichoke in the bagna cauda. So If you haven't got artichokes because they're out of season, use something else, because bagna cauda, the typical Piedmontese dish with garlic and anchovies, is the best thing. I'm very sorry, but we have to leave you time. Is it true that we should not, this China study, we shouldn't eat, all the vegans, everybody have become vegan. Is it true that we have to eat less chicken? I would eat less chicken and have another kid. I think that the figures are not so clear. So it's a big study, but they haven't got, in certain Chinese groups, there's no breast cancer. Why? Surely. But then there are all the studies on the food on the basis of soy, because soy food apparently has a protective role, but they have to be taken when you're a child. So in these populations, possibly, this is so. So even now, if we go to the Chinese restaurant now, no, you have to use it from childhood, and this is what seems to be the protective effect. Oh, GMO soy, I insist, because we do these from the Science Festival. Yes, genetically modified organisms are fine. We'll tell you about the chicken next year. Thank you very much. I'd like to thank everybody. I'd like to thank GiovedìScienza Science on a Thursday. And I'd like to thank our scientists and Teresa Mannino, who spent some time with us. And thank you. And thanks to you all. Thank you.